Good evening, everyone. This is Courtney at NATF. Thank you for joining our August online support group. Before we get started, please remember that if you have a question, to submit it using the chat function in the GoToWebinar toolbar, or send it to info@natfonline.org, where we will be monitoring that email for the duration of this webinar. We are delighted to have Dr. Alec Schmaier join us this evening. Dr. Schmaier is a cardiologist and vascular medicine physician in Boston. His research focuses on how dysfunction in the cell lining of our blood vessels predisposes people to thrombotic disease. Dr. Schmaier has a particular interest in venous and arterial thrombosis and the medical conditions that predispose patients to blood clots. Vascular disorders other than heart attack and stroke are often underappreciated by both patients and physicians, and Dr. Schmaier believes that vascular medicine can help bridge that knowledge gap. Dr. Schmaier obtained his MD and PhD from the University of Pennsylvania, and his graduate work focused on activation of platelets by collagen and other vascular wall proteins. He completed his residency at an internal medicine at the Hospital of the University of Pennsylvania. Thank you, Dr. Schmaier, for joining us this evening. I will now hand the controls over to you so you can begin your presentation.
Thank you, Courtney, for the lovely introduction, and thank you to NATF for inviting me to be here. It's really exciting. I think this is a great opportunity for outreach, and I really look forward to the talk and for the questions. So my name is Alec Schmaier, and I'm a cardiologist and vascular medicine physician. My research is, and I did all my clinical training at Brigham and Women's Hospital. I work in a laboratory now at Beth Israel Hospital across the street, and I'm actually coming on staff at Beth Israel Hospital this fall, so I'm pretty excited about that. Today we're going to talk about updates on venous thromboembolism prevention and treatment. I don't have any disclosures. A couple terms today that I'll be using a lot. I'm sure you're all familiar with them, but VTE means venous thromboembolism, which includes DVT and PE. DVT is a deep vein thrombosis, a blood clot that forms in the veins, usually in the leg, but sometimes also the arms. And a pulmonary embolus is when that blood clot breaks off and travels to the lungs. And I'm sure many of you are familiar with the signs and symptoms of VTE and how they're diagnosed. I'm not going to talk about that specifically, but certainly happy to answer any questions about that. What I do hope to talk about is just an introduction to the different anticoagulants or blood thinners that we use in clinical practice. I'm going to talk about prophylaxis, so prevention of VTE in high-risk medical patients. I'm going to talk about new data for the treatment of cancer-associated VTE. I'm going to talk about prophylaxis for VTE in high-risk cancer patients. So there's a theme here. And then I'm going to shift gears at the very end and talk a little bit about antiphospholipid antibody syndrome and some new studies associated with that. And then at the end, I will take any questions. So basically, there are different medical organizations that issue guidelines for the diagnosis and treatment of VTE. The most recent guidelines came from the American Society of Hematology and were published in 2018. And I encourage any of you to go to the ASH, the American Society of Hematology website, and peruse these guidelines. There's some great teaching slides and patient handouts. So first of all, I just want to talk about the different blood thinners that are in practice. Unfractionated heparin is often the most common blood thinner that's used, especially when a patient presents with a new diagnosis of DVT or PE, but it's also used for prophylaxis of venous thromboembolism. When it's used for treatment, it's given through IV and a continuous IV infusion. When it's given for prophylaxis, it's given subcutaneously through the skin by a small needle. And we like this drug because it is given as a bolus and you get a quick onset and offset of action. It can be used in patients with kidney disease or liver disease. There's an antidote for the drug if we need to reverse it, and you can adjust the dose frequently to achieve the correct amount of anticoagulation. The drawbacks are that it requires frequent blood draws in order to have that monitoring. Because it's given by an IV infusion, the patient is kind of tethered to an IV pole, which makes it harder to move about. It can be tricky to achieve the ideal dose because the pharmacokinetics and pharmacodynamics are somewhat variable. And it has some unwanted side effects, such as heparin-induced thrombocytopenia, where you have an immune reaction and the heparin can cause your platelets to basically be attacked. So because of these undesirable issues affecting heparin, low molecular weight heparins, such as enoxaparin, also known as Lovenox, or fondaparinux, also known as Arixtra, have been created. These have a very standardized dosing that is basically weight-based. It is given by subcutaneous injections, so there's no being tied to IV poles. It may actually be more effective at reducing clots and associated with less bleeding events. The downsides are that these drugs are cleared by the kidneys, so if you have kidney disease, you can't use them or you need to be monitored very closely. And the heparin antidotes are less effective for these medications. Now, for oral options or anticoagulants that you can take by mouth, warfarin is kind of the first one to come to clinical use, and it's the most tried and true medication. It can be used for any type of anticoagulation for blood clots, but also atrial fibrillation, mechanical heart valves. It can be used if there's kidney dysfunction. You monitor the amount of drug that's in the system and how well you're anticoagulated, and there's established protocols for reversing warfarin. It's very potent, and it's actually somewhat forgiving. You can skip some doses. The downside is that it requires monitoring in order to maintain the patient in the therapeutic window, and that can be pretty cumbersome. And because it's long-acting, it takes a while to get into the body and also takes a while to go away. So you need, if you're starting on it or you need it to be interrupted for a medical or surgical procedure, you have to be bridged with heparin. There's also a lot of dietary restrictions and drug-drug interactions, and it may be associated with more bleeding than with heparins. And the newest drugs to market, really to address some of the undesirable issues associated with Coumadin or warfarin, are the direct oral anticoagulants, also known as the DOACs. And there are now 5 of these drugs on the market. They don't require any monitoring. It's basically one standard dose for all patients. They are associated with less bleeding than warfarin, but are equally effective. They have a rapid onset, and they have a shorter half-life, meaning they're out of your system quickly if you need interruption. The downsides are that we don't have as much of an established means for reversing these drugs, but kind of hot off the press, there are now reversal agents that are available IV that have been studied and are safe and effective. And so these are going to be used in clinical practice more frequently. I'm not going to talk any more about that, but happy to take any questions. The fact that they have a shorter half-life is also a downside too, because it means it's very important that you don't skip any doses, because the drug can go out of your system more rapidly, and therefore you're not safely anticoagulated. You can't measure drug levels as easily, and so that can be a downside if we need to know. And because it is just, they're newer to market, they haven't been studied in kind of all the indications that warfarin has, like mechanical heart valves and things. They can't be used for that. We'll talk a little bit more about that. So prevention is the best medicine, and I think it's important to talk about how we can prevent venous thromboembolism in different settings. So VTE is very common in medical inpatients, so people who get admitted to the hospital and for a medical illness like a pneumonia or heart attack. And actually about half of all VTE events basically occur in hospitalized patients. And this kind of makes sense when you think about it. People who get admitted to the hospital often have risk factors for VTE. They may be older, they may have indwelling catheters, they may have cancer, but just being hospitalized in and of itself is a risk factor for VTE because you're often immobile, you're in a bed. And what's important is that this risk of blood clot stays elevated even after you've left the hospital. So who is at risk for a VTE? Well, there are different risk assessment models that can identify people in the hospital who are at high risk. These are some of the names of them. And they haven't really been validated well in studies, but certain things are pretty common to all of these risk predicting modules, like advanced age, having cancer, being overweight, and being immobile. And so if you think about it, it's very common for someone in the hospital to have several of these risk factors. So the guidelines and different guidelines from different organizations are pretty clear on this, that patients who are ill and hospitalized should receive pharmacologic prophylaxis. That means with a drug, and that drug is a heparin with low molecular weight heparin favored over standard heparin. And mechanical prophylaxis, meaning an intermittent compression device or a compression stocking, should really only be used if the pharmacologic, the heparin medication, can't be administered. And I think the big question is, should prophylaxis be extended beyond just the hospital stay? So we'll talk about that in a second. The only point I want to emphasize is that for patients, if you are hospitalized, you should be aware of the risk of venous thromboembolism if you're not already on anticoagulation. And the low molecular weight heparin, like enoxaparin, is just given once a day compared to standard unfractionated heparin, which is given 3 times a day. Those shots are often uncomfortable. And so if you're getting the 3 times a day shot, ask your doctor if it's reasonable for you to be on the once a day shot instead. It's going to be easier for you and for your doctor, and it's associated with less risk of blood clot and less risk of bleeding. So why would we hospitalize patients after they leave? Why would we give VTE prophylaxis for patients after they leave the hospital? Well, about 8 million patients are hospitalized each year and are at increased risk for VTE. And this results in the US alone of about 200,000 VTE events, including an estimated 25,000 PE or DVT related deaths. And basically 1 out of every 2 DVTs or PEs occurs within 6 weeks of leaving the hospital. So can we come up with a strategy to prevent VTE even after you've left the hospital? And this makes sense when you think about it. You're getting heparin shots while you're in the hospital. It's not like once you go home, you're necessarily up and running around again. It takes you a while, sometimes a couple weeks, to be back to normal. And so if you're still spending a lot of your time in bed or on the couch after you get home, your risk for VTE is still elevated. And so a few clinical trials have looked at a strategy to reduce VTE risk after hospitalization. These trials are called the ADOPT trial and the Magellan trial, and they basically compared in-hospital enoxaparin with in-hospital enoxaparin plus either apixaban or rivaroxaban. These are 2 of the DOAC drugs, after you leave the hospital. So basically, patients would get standard in-hospital prophylaxis, and then that would either be stopped or they would go home on one of the DOACs. And what they saw was that actually, and they followed these patients for about 30 to 45 days, and they did see a reduction in VTE events. But unfortunately, these came at the expense of increased bleeding, and the amount of VTE reduction was fairly modest. So in order to try to improve upon this, a newer trial was done with a novel agent that may be more effective and also safer. So this was Betrixaban, and this is now on the market, but basically it's only used for prophylaxis of VTE, and it may be safer because it's very, it can be used in patients with kidney dysfunction because it's not cleared by the kidneys. It has a long half-life, so it hangs around for a long time and you don't get spikes in the amount of drug in the system. And it basically has a rapid onset, and it's been demonstrated to be safe in over 1,000 patients in early phase clinical studies. So this trial that's looked at Betrixaban was called the APEX trial, and it tried to enroll patients who are at a higher risk of VTE. So this is someone who's 75 years or older, or younger, but with an elevated D-dimer, which is basically a marker of clot breakdown in the bloodstream, which may suggest that the patient is at higher risk for a blood clot. And the patient had to be hospitalized for at least 3 days and immobilized for about 24 hours of that hospitalization. And they need to be hospitalized for one of the following indications, which represent fairly severe illness. And what these investigators found was that Betrixaban, when it started in the hospital and continued for about 35 days after hospitalization, reduced blood clot events by about an absolute reduction of about 25%. And a number needed to treat, meaning how many patients need to be treated to prevent an event, of about 58 patients, which is pretty impressive. And this actually came at the expense of no increased risk of bleeding. That's shown in the columns on the right. And what you'll notice is that compared to the other trials, the overall incidence of VTE events was much higher than the other trials, showing that the investigators did achieve their goal of enrolling a group of patients that are at higher risk for blood clots. And the fact that there is much less bleeding, or sorry, no difference in bleeding, is very encouraging. And another trial kind of looked at the same issue, trying to enroll patients who are at higher risk for VTE, and also used rivaroxaban at a prophylactic dose. And they also saw a reduction in VTE events. The investigators of the APEX trial actually included asymptomatic venous thromboembolism events. So all these patients got an ultrasound scan, and a lot of the events were actually asymptomatic events. And so some of the criticism was, well, what's the importance of an asymptomatic event? So in this trial, the Mariner trial, they only looked at symptomatic events, and they saw a reduction with rivaroxaban given after hospitalization. But there was actually no reduction in VTE-related death in this trial or in the APEX trial, which is one of the criticisms. So the net benefit of extended prophylaxis is a little bit unclear. This is a slide that actually one of my colleagues made from a paper, which is really fantastic, looking at all the trials. And basically what you want is a safe, low risk of bleeding if you're extending someone's prophylaxis, but you also want to be effective at reducing VTE. And so the APEX trial with Betrixaban really achieved that. You don't need to treat, the NNT is the number of patients needed to treat to prevent a major event. That's about 200 patients. And you need to treat almost over 3 times as many before you cause a significant bleed. And so this is a very favorable risk-benefit ratio. However, the most recent guidelines don't recommend extended post-hospital prophylaxis, and they claim this is due to the absolute reduction on VTE is quite small. You need to treat hundreds of patients to prevent one symptomatic clot. And they say it's similar to the number of bleeding events caused, although I would say this is not true. The extended prophylaxis does not reduce mortality. This is true, although we haven't followed these patients for an extended period of time, and so the implications of having a blood clot on your mortality, 6 months or a year later is unclear. And so I do think that it's worth working to find the patients who are hospitalized who are at the absolute highest risk for VTE, and there are more trials looking at this. So this is somewhere to stay tuned for the future. However, I would say that if you are a patient who is at high risk for blood clot, you should know your risk factors. And if you're not already on anticoagulation, you may want to talk to your physician if post-hospital prophylaxis may make sense for you. And I would favor betrixaban as the agent to use if that's agreed upon with your physician. So shifting gears to another element of prophylaxis, this comes up a lot, air travel and venous thromboembolism. So when we talk about air travel, we're really talking about long distance flights, which are 4 hours or longer. And this does increase the risk of a blood clot by almost threefold. And so for those who are at increased risk, we actually recommend wearing compression stockings or even taking a single dose of prophylactic low molecular weight heparin. And if either of these aren't available, aspirin is a great option. I often just recommend aspirin to patients because they may not be able to get a prescription for enoxaparin, or if they have one, it may have expired. If you haven't worn compression stockings before, it's kind of difficult to get fitted and use them properly. Taking an aspirin is likely just as effective, and everyone can find some baby aspirin, 81 milligrams, pretty easily. So who's at increased risk for a travel-related VTE? People who have a history of VTE, who aren't on anticoagulation for extended anticoagulation, people who have had recent surgery or recently gave birth or have cancer, or if you have a combination of hormonal replacement, being overweight or pregnant. It's important to note that there are not a lot of studies that looked at these risk reduction things, but basically the risk of taking aspirin or heparin or compression stockings is very small, and so it makes sense to reduce your risk if you can. So putting this into context, I talked about the phases of anticoagulation at my last patient support group. I just want to emphasize that prophylaxis is really important, and prophylaxis may include low molecular weight heparin, standard heparin, betrixaban. If you're a surgical patient, especially orthopedic surgery, they use DOACs for prophylaxis in that setting, or even aspirin in the case of air travel. And this fits into the context of treatment for a blood clot after a clot has occurred, where you may be on IV heparin or sub-Q low molecular weight heparin or DOAC in the initial treatment for the first couple weeks. You may stay on a DOAC, a heparin, or warfarin for 3 to 6 months to treat the blood clot. And then beyond that, your doctor and you may decide that extended duration anticoagulation makes sense. And this could include warfarin, low molecular weight heparin in cancer patients, or DOAC, or even aspirin, or no anticoagulation. And happy to answer questions about that, but I'm not going to go into more details at this time. So shifting gears to cancer and VTE, you are probably aware that cancer dramatically increases the risk of having a blood clot. And this is due to a lot of different factors. First of all, cancer itself can promote platelets to activate and blood clots to form. Sometimes the chemotherapy itself is noxious to the blood vessels. Patients are often immobile, or they may have compression of the veins from a tumor that causes stasis. And patients often undergo surgery, which surgery itself is a strong risk factor for VTE. Additionally, patients may have indwelling catheters that basically are a foreign body in the blood and promote blood clot formation. So we know that cancer patients are at a big risk for VTE. And in patients who develop blood clots, the standard of care has been low molecular weight heparin after this seminal trial that was published over 15 years ago, showing that low molecular weight heparin was more effective at reducing recurrent VTE compared to warfarin, and also, I don't have it here, but also resulted in less bleeding compared to warfarin. And follow-up trials have supported the use of low molecular weight heparin over warfarin, although not to the same level of statistical significance that the original trial demonstrated. However, anyone who has had cancer and been on enoxaparin has probably developed a very love-hate, or maybe more hate, relationship with their Lovenox shots. It is quite cumbersome to inject yourself twice a day or once a day for 3-6 months or indefinitely, and both patients and physicians would very strongly welcome any oral alternative to the heparin shots. And so obviously, with the emergence of DOACs, the direct oral anticoagulants, there was an instant interest in seeing if these would be effective for treating cancer venous thromboembolism. And it actually was only last year that the first trials examining this were published. And so this trial looked at edoxaban, which is also known as Savesa. It's a newer DOAC that's probably not used as frequently. And this was used in patients who had a VTE and had active cancer. The definition of active cancer was a little loose, but basically either patients who were not cancer-free or were receiving chemotherapy. And so this was comparing edoxaban to a low molecular weight heparin, and there basically was no difference in the risk of recurrent clot combined with the risk of having a bleed. When you break these down into two separate components, you actually see on the left that edoxaban reduced the risk of recurrent venous thromboembolism. But if you look at the right, it actually was associated with more bleeding events. So overall, they were equivalent, but it seemed like edoxaban was associated with more bleeding. And what the investigators found was that the bleeding events tended to occur in patients who had cancer in the GI tract, esophageal cancer, stomach cancer. And so this raised some alarms about using the DOACs in GI malignancy patients. Another trial showed similar results. This is the SELECT-D trial, which used rivaroxaban or Xarelto in patients who have cancer-associated VTE, and it saw similar results. There was less VTE recurrence with Xarelto compared to low molecular weight heparin, but there were more bleeding events with Xarelto compared to heparin. And these investigators found that the bleeding events also were much more concentrated in patients who had cancer in the GI tract, so much so that they actually changed the protocol several months into the trial to no longer enroll patients who had cancer of the GI tract, because of the increased risk of bleeding. So can we use DOACs for cancer-associated VTE? Overall, they certainly appear effective compared to heparins, but there are some safety concerns. Nothing for DOACs has emerged in the guidelines yet. It's still considered unknown. Oops, I'm going backwards. I would say that, not all cancer-associated VTE is the same. We certainly see patients who seem to have a very aggressive thrombotic presentation, especially when they're newly diagnosed with cancer or they're receiving chemotherapy. This is different from someone who has cancer and maybe had a clot form around their port or their PICC line. Those are kind of two different things. Sometimes I start patients on a low molecular weight heparin for the initial 6 weeks or 3 months and then switch them over to a DOAC. There are certainly practical implications. You have to be able to take pills. You can't be nauseous or vomiting all the time. You have to pay attention to kidney function, really for both drugs. But these are some of the considerations. I would say that we should definitely avoid using DOACs in patients who have cancer in the GI tract. But this is still an area of ongoing investigation, and there's new trials looking at DOACs for cancer-associated VTE that are in the works right now. And so the natural question is, can we use prophylaxis to prevent VTE in cancer patients who are at high risk? So I've told you about medical patient prophylaxis, extended prophylaxis, but cancer patients are at a much higher risk for VTE, and yet there are no standard VTE prophylaxis protocols in place and no recommendations really by the guideline committees. However, this year, 2 large clinical trials were published called the AVERT trial and the Cassini trial. And what they did was they took patients who have cancer and a Corona score, which is a risk factor score of greater than or equal to 2. And these patients were about to start chemotherapy, which is a period of increased risk for blood clots. And the Corona score is basically a risk score that takes into account the type of cancer that the patient has. Some cancers are known to be much higher risk for causing blood clots, and other factors like a low hemoglobin level, a high white blood cell count, a high platelet count, or obesity. And these trials randomize the patients to no prophylaxis or prophylaxis with apixaban or Eliquis in the case of the AVERT trial, and rivaroxaban or Xarelto in the case of the Cassini trial. And basically what they found was that it was effective. So they needed to treat only about 24 patients to prevent one blood clot. Now, these patients all underwent ultrasounds as part of the screening procedure after enrolling in the trial. And so some of these blood clots weren't symptomatic, but you only needed to treat 40 patients to prevent one symptomatic VTE. So compare that to the trials for the extended prophylaxis in medical patients, where you needed to treat hundreds of patients to prevent a symptomatic blood clot. In these trials, it was only about 40 patients. And the kind of safety index seemed reasonable. You didn't have any bleeding events until you treated about 80 patients. So about 2 to 1 in terms of preventing a blood clot to causing a bleed. With that said, I don't think there's been a huge amount of excitement for these results yet. It's kind of a good proof of principle, but it's a little unclear whether this is generalizable to a larger subgroup. Clinical trials select the patients that are at highest risk, but also aren't as sick from kind of a general medical standpoint. We know that patients with cancer can be extremely heterogeneous. There's a lot of variability. And so it's unclear if this is going to change medical practice, if oncologists are going to use this in standard fashion to prophylax cancer patients. But I think these results are very encouraging. It makes a lot of sense. And so there's going to be more data in this regard coming down the pike soon. So finally, I'm going to touch on a condition called antiphospholipid antibody syndrome. And this is an autoimmune thrombotic disease where your body generates autoantibodies that promote blood clot formation. And the disease is characterized by recurrent thrombotic events that can occur in the veins or the arteries, and is also associated with recurrent pregnancy loss. And it's an aggressive thrombotic disease, and because of this, the standard of care has always been warfarin. But obviously, because of the inconveniences of using warfarin, patients and physicians want to know, can we use the DOACs? And so, and people have used the DOACs kind of in small groups and shown some favorable results, but in other groups there have been some less than desirable results, so it was unclear. And this year, a trial came out that looked at Xarelto versus warfarin in high-risk patients with antiphospholipid antibody syndrome. So high risk meaning they've had a blood clot before, almost all of them, and they have all three of the antibodies that are associated with antiphospholipid antibody syndrome. Basically, you only need one of these to be diagnosed with the syndrome. These patients have all three, so they are, by definition, at higher risk for recurrent events. And unfortunately, Xarelto did not fare well in this trial. There was an excess of recurrent events. These could be pregnancy loss or blood clots while taking Xarelto compared to warfarin. And so so much so that the trial was actually stopped early. This was a little bit ambitious to try to use a DOAC in the highest risk patients. Again, just like cancer, antiphospholipid antibody syndrome is heterogeneous, and some patients are going to be at higher risk than others. But certainly, we have to kind of pause after seeing these results and take a step back and reconsider the patients that DOACs are going to be most appropriate in. So a few wins and a few losses in updates for VTE prevention and treatment. That concludes my planned talk. I want to thank NATF for inviting me out. I want to thank Catherine and Courtney for organizing such a fantastic seminar, and Dr. Sam Goldhaber for putting this all together. And now we can switch to questions, which is really my favorite part of the talk. I thank you so much for your attention.
Thank you, Dr. Schmaier. We had a lot of questions come in during your presentation, so I will get right to it. The first question we had, a patient reached out that has a prothrombin gene mutation and had a PE. She's considering having a knee replacement, but has been advised against it due to being high risk. What would you recommend for this patient if having a knee replacement would provide a better quality of life?
Yeah, I mean, that's such a great question because these kind of scenarios come up not infrequently. There's no single right answer, and it's hard to really evaluate the case without all of the details, but I will certainly say that having the knee replacement, I can't prohibit that. It's certainly reasonable in the right circumstances to proceed. If the patient is not currently taking anticoagulation for whatever reason, then there are definitely effective prophylactic strategies after knee replacement. The risk of having a recurrent event is certainly higher than the average patient, but I wouldn't say that it's completely prohibitive. It depends on how bad you want the knee replacement to be done and kind of the circumstances surrounding the blood clot. I think, unfortunately, without more details, I can't really give a more specific answer.
Okay, no, that was great. Thank you. Another question, another patient would like to know if there's a lifestyle change or a particular diet that would help with collagen and wall proteins to decrease the potential repeat of a PE besides a DOAC?
Yeah, that's a great question. And, what we do know is that all of the thrombotic disorders, which include VTE, heart attacks, and strokes, all of the risk factors overlap. So things, lifestyle issues like weight reduction and exercise and healthy diet can certainly decrease the risk of recurrent events. Unfortunately, we don't have a lot of specific data on the right diet to actually reduce the risk of blood clots. Even for a more common condition like heart attacks, we have very limited data about what diets are actually effective. In general, we know that lowering cholesterol and triglycerides decreases the risk of heart attacks, strokes, and blood clots. So I could, in theory, recommend a more Mediterranean type diet rich in proteins from fish and nuts and high in olive oils and low in red meats and processed carbohydrates. That's kind of the general dietary advice I give to every heart and vascular patient. And I wish I could be more specific. We just need to learn more about this.
Interesting. So, do you know of any fad diets that may affect warfarin that you know of?
Yeah, it's specifically, I do not, but it's certainly something to watch out for. I can't say, oh, you want to go on a keto diet, you're going to have to decrease your warfarin dose. I don't know if that's true. The classic thing is that diets rich in vitamin K will increase your requirement for warfarin. So I don't think in general that there's any hard and fast rule. What I recommend is that if you're thinking about making a serious adjustment to your diet, you alert your physician, and we can always monitor your INR or your warfarin levels as you make the change. And if you are changing your diet, be consistent. Choose one thing and stick with it, because varying your diet a lot can really wreak havoc on your warfarin levels.
Okay, thank you. The next question we have, do you find any correlation between superficial vein thrombosis and DVT and the treatment for SVT if someone presents with factor V Leiden or antiphospholipid syndrome?
Yeah, that's a great question. So there's certainly, the idea that a superficial venous thrombosis, so that's a vein, a clot that's basically not in the deep vein, is different from a DVT is really not true. They're all kind of part of the same thrombovascular inflammatory condition. And superficial venous thrombosis is usually at lower risk for causing a pulmonary embolus, much lower risk, and they may often go away on their own. However, if they are associated with an autoimmune condition like antiphospholipid antibody syndrome, a superficial venous blood clot could herald the development of a more severe clot. And so I think that in general, they need to be addressed on a case-by-case basis. But for superficial venous thrombosis that doesn't go away with kind of just supportive care or is more extensive in nature, we do use low-dose anticoagulation, either with a DOAC like Xarelto or Apixaban, or with low molecular weight heparin to treat that. But if it seems like the line is blurred between superficial venous thrombosis and a deep vein thrombosis, especially in something like antiphospholipid antibody syndrome, we may have a low threshold to start someone on warfarin in that case. But all of this really has to have a lot of shared decision making and discussion about the risks and benefits with the patient.
Okay, great. The next question that we have is, should a child of a person who has multiple blood clots or PEs who's in their 20s with no known genetic markers avoid long plane flights, especially if that child is tall and be sure to be in a cramped seat?
It's a good question. And this question raises an important point. People and patients and physicians like to hang their hat on, do I have a thrombophilia? Do I have factor V Leiden or prothrombin gene mutation, something I can test? We know that those mutations actually account for a very small fraction of the heritable risk of blood clots. So the fact that you have an immediate family member who had multiple blood clots, that is your risk factor for having a blood clot. Not necessarily, you can't be reassured just because you don't have factor V Leiden. Now, the only caveat to that is if your family member had factor V Leiden or prothrombin and you don't, then you got lucky and didn't inherit the thrombophilia. But there could be other genes involved too. So I think the answer to your question is that you should be concerned about your increased genetic risk of blood clot. And I think that I wouldn't prohibit long plane flights, but you may want to take an aspirin or take a low molecular weight heparin shot and make sure that you get up frequently and move your legs. Still, the risk of having a blood clot for a long flight is very small, but you can probably take some steps to reduce that risk.
Okay, and in addition to that question, would you take the regular dose of aspirin for somebody who may be 230 pounds, or would it be just the baby dose?
Yeah, that's a good question. I mean, I think that, if you have no history of bleeding, then you might as well take the larger dose of aspirin. But I think that you could go either way. But if you're concerned, then just taking the large dose of aspirin may be better in that case, if you're a large person.
Okay. And we do have a lot of travel questions, as it's obviously something that people do all the time. But
Cool.
If you had a patient with 2 prior PEs, but related to travel, would you keep them on a blood thinner going forward?
Yeah, it's a good question. I mean, overall, the risk of travel-induced blood clot is small. And so, could there be other stresses that could cause another blood clot to form? Because obviously people travel all the time and most people don't get blood clots. So I think if you've had 2 travel-related blood clots, I'd be concerned that you just are at some increased risk for having a blood clot, and I would strongly consider being on extended dose anticoagulation with a lower dose DOAC. And that's something to bring up with your physician. I would probably recommend it.
Okay. So we have another patient who had a provoked DVT or PE about 4 years ago and was on Xarelto for 6 months and switched to a baby aspirin, but they take a low dose Xarelto when they fly longer than 4 hours. There hasn't been another VTE, but since it's been almost 5 years from the initial incident, would you recommend staying on aspirin or perhaps going back to the low dose DOAC for prevention?
Yeah, I think you're bringing up a good point that there have been, and I talked about this at my last patient group, that we now have good data looking at lower doses of DOAC for an extended period of time as kind of extended prophylaxis. I mean, I think this really comes down to your preference. The fact that you've had 5 years without an event bodes very well, and aspirin is still effective at reducing the risk of recurrent clot. So I think that you don't have to switch back to going on a DOAC. I think this really comes down to your personal preference. If you want to do all that you can to prevent another clot, then a DOAC is reasonable, knowing that that comes with an increased risk of bleeding compared to aspirin, and also increased expense likely because the medication is not generic. So you're just kind of shifting your priorities. But I certainly don't think that you are mandated to go back on Xarelto. Sounds like you've been doing very well on aspirin alone.
All right, so we have a warfarin question. If someone is on warfarin for AT3 deficiency and factor V Leiden, can they be given TPA in the case of a stroke?
Well, if you are on warfarin at the time of a stroke and you are therapeutically anticoagulated, then that is a contraindication to giving TPA. If you are, but otherwise, if you are not on warfarin but just had those thrombophilias, then I don't believe there's a contraindication to giving TPA. But if you are therapeutically anticoagulated with warfarin, that's not safe to give TPA, I believe.
Okay. So with all other labs being normal, how relevant is a protein C deficiency in regards to risk for future PE?
I would have to look that up to see what the studies show. It's pretty high in terms of the risk for protein C deficiency. I'm going to say off the top of my head, maybe a 5-fold increased risk. It's more rare than some of the other thrombophilias. And the other thing that protein C deficiency is associated with is warfarin-induced skin necrosis when warfarin is started. So that's also something to watch out for. I'm sorry, I don't know off the top of my head the exact increased risk, but whatever it is, it's probably not super accurate because we actually, there aren't that many of these patients that we have studied.
Okay. Another question for you. If someone has inherited AT3 and factor V Leiden and is a preteen and has never clotted, should they be treated with anticoagulants?
So the answer is no. They should not be treated with anticoagulants, but they will require prophylaxis under certain circumstances. So if the subject in question is female and gets pregnant, pregnancy is associated with increased risk of blood clot. And so given those combined thrombophilias, which are quite high risk, it may make sense to actually be on Lovenox during pregnancy. If the patient had an elective surgery, I would probably recommend extended prophylaxis after surgery, and probably recommend prophylaxis during travel, but they shouldn't be treated in the absence of those scenarios just because of that gene mutation.
Okay, great. Actually, in relation to birth control, are there any concerns with taking a progesterone-only birth control for someone with a previous VTE? The birth control is being used to minimize heavy menstrual bleeding due to taking a DOAC.
Yeah, as far as we know, progesterone-only birth control is safe and does not increase the risk of blood clot formation. So that is a reasonable alternative if birth control is required and estrogen containing contraceptives are contraindicated.
Okay. So you mentioned asking a doctor to switch to possibly one dose of low molecular weight heparin since it's better and easier for both the patients and providers. Why is the 3 shots of the standard weight still a form of prophylaxis?
Yeah, well, it's still used because, well, one, the sad reason is that unfortunately people are lazy and don't, now we click the orders in the electronic medical system, but sometimes they just click the 3 times a day instead of the once a day Lovenox. But there are real reasons. So if the patient has kidney dysfunction, they can't get the once a day low molecular weight heparin. If the patient is at extremes of body weight, we often give the standard heparin. If the patient is at a very high risk for bleeding, we give the standard heparin because it can be reversed more easily and goes out of the system more easily. So there definitely are scenarios where you can only give or would prefer to give the standard heparin, but I think among all comers, the default should be once a day low molecular weight heparin unless that can't be used.
Okay, and another comparison of anticoagulants, since there are a lot of cons with warfarin, such as monitoring and less bleeding, and there are more pros with DOACs, why do you continue to recommend warfarin versus other DOACs?
Yeah, so if I wouldn't recommend warfarin, with the exception of antiphospholipid antibody syndrome. For a new diagnosis of a blood clot, I only use DOACs. There are, I have many patients though who have been on warfarin before, and before the DOACs came into clinical use, and warfarin has worked very well for them, and so they've kind of proven that they tolerate it, and often they want to stay on warfarin. I recommend. I offer to switch to a DOAC. Often they prefer to stay on warfarin, which is totally reasonable. Sometimes there are patients that you kind of want to be able to monitor them a little bit closely, maybe patients who you're worried that they may not take the medication, or they may kind of not be in contact with a physician. Being on warfarin can help because you're interacting with an anticoagulation pharmacist, kind of keep patients in the loop. But the short answer to your question is no, I don't recommend warfarin as the initial anticoagulant if I'm starting someone from scratch on a blood thinner.
Okay, interesting. We have one more question for you. This patient survived a ruptured brain aneurysm followed by multiple PEs in 2013 and has not had any blood clots since. An elective surgery has been denied because they've been told that they would have a fatal event. They do have factor II genetic gene mutation. What are your thoughts?
Well, yeah, I mean, again, so it sounds like the blood clots occurred after the aneurysm rupture, which I'm sure, well, I imagine was a pretty extreme hospitalization. And once you're hospitalized with critical illness, like I talked about, your risk of having blood clots get really high. So it sounds like those were provoked blood clots. And, the fact that there is a prothrombin gene mutation, you may have never discovered that out of the context of having a provoked blood clot. Now, this gets into a discussion of, can a blood clot ever be truly provoked or unprovoked? Are you at increased risk for a blood clot? Yes. But the fact that these PEs occurred in the context of a hospitalization for a critical illness and not just out of the blue probably means that you're less likely to have a recurrent event. And again, if you are still on anticoagulation, that can be interrupted for the time that you're on surgery, and then restarted after the surgery is complete. So I think again, there's no absolute here. It depends on how important the elective surgery is. But I think the fact that these clots were provoked actually helps your cause because the risk of recurrence is lower than if they were unprovoked events.
Okay, wonderful. That's actually all the questions that we got. So thank you everyone for joining us this evening. We hope you learned a lot. As a reminder, all of our support groups are recorded and available for viewing on our website. The next online support group is scheduled for September 17th, and we will be joined by Dr. Jeff Barnes from the University of Michigan, who will be presenting on new research in the field of blood clots. We hope to see you then. Dr. Schmaier, thank you for a very informative evening. It was a pleasure.
Thank you, Courtney, and to NATF for inviting me, and thank you everyone for tuning in, and thank you for your wonderful questions. I wish you all the best of health and happiness.
Thank you. Have a nice evening, everyone.